L1. And if it is a retrocrural, then the patient is prone position, then you can see that the celiac plexus would be T12 L1, and here it is between celiac plexus. And these are you can identify T12 L1 by identifying the rib, because the rib, if you identify in the fluoroscope, then you can identify which is the T12 and then goes to the L1. Now, normally, this is what I do in a prone position. Needle are inserted at the level of first lumbar vertebrae, normally 5 to 7 centimeter in the normal adult, 70 kilogram normal height and weight. So 5 to 7, because 2 away, there's a danger of the damaging kidney. So you cannot attempt the needle 2 away, 7 or more than 7 centimeter away from the central line. Similarly, too near is also difficult to go there, and the chance of early cannulation of the major vessels. So tip of the needle is directed towards the body of the L1, because now you have to go in front of the T12 or L1 level. So you have to actually understand that the patient is prone and you are passing the needle there, and your needle tip should be in front of the L1, how we would go. So most of the time under fluoroscopy, even you have to, at the end, you have to hit the L1 vertebral lateral body. If it is a vertebrae, then you are going here, then this has to be like this. And you keep walking off until you get at the interior level of the L1 vertebrae. So this is the needle placement. You can see that. Normally bilateral, it all depends, person to person variation. If you have two hand assistant, normally we do first on the right side, right inferior vena cava, and then we go to the left side, but people are doing simultaneous at the same time. This is some of the radio frequency images, then how the things look like. So you have to see, whenever you do this for all interventions, you have to do your area of work in all possible images, the lateral, the apilateral image, the oblique. So these are very two common images. Then you have to see the dye spread, which has to be longitudinal. And when you do the work around the spinal cord, vertebral body, one concept, that is a red zone, one must have. I mean, the red zone means that the canal, that is the spine processes, when we see in that area, when we should not intervene. So you have to be peripheral to the red zone. So your needle tip, your dye and things should not be in the red zone, because that means that you are in the canal area. That's important. So you have to see in the lateral image, and in the lateral image, and you have to also see in the anterior, the AP image and the lateral image. So you can see the lateral spread and the anterior spread. Now, choice of the agent, I have told you about that if you are doing diagnostic, and one should try to convince the patient that he should have a feeling, you should have a trial of the diagnostic first. So the patient should have a good idea that how it would feel like. And the literature said even in the diagnostic block, sometimes the addition of the methylprednisolone depomedrol is effective in prolonging the effect of the diagnostic block. Otherwise, you can do the neurologic procedures, which is between 50 to 100%. Complications, there's a list of complications, but the people who are doing it, we don't see very frequently all these things. Hypertension, normally we treat by the fluid therapy. But the postural hypertension, normally patient have for a couple of days and sometimes weeks, and we reassure the patient that how this orthostatic hypertension will go away within a week time. Diarrhea again is a part of your procedures. It is like a pathophysiological sequence, and it is again showing the success of the block. The diarrhea normally patient have, because if the sympathetic block is is a successful, then of course the other part, the autonomic, the parasympathetic, would more be activated. Then the backache, then dysthesia, intrascapular back pain, these all kind of complications, not the complications, it's more of the side effects, are written in the books. But the people who are doing the procedures, like we are doing quite, because we have a palliative care set up in our institution, and also the cancer pain is a lot of, so we are doing that. But we don't have much of these problems. Although the hypotension, the orthostatic hypotension and diarrhea, we normally prepare the patient that it may happen within 2 to 3 days, and patients are mentally accept that. So thank you very much. This is a brief presentation and focus, because Gautam told me, because he's actually coordinating all these things, that we have to focus on the procedure part rather than more theory and things like that. Am I right, Gautam? Thank
Dr. Gauhar Afsan, and Medical College and Civil Hospital, Ahmedabad, India, to present a topic, intrathecal drug delivery system.
Good morning, everyone. What I'm going to talk to you is not going to be demonstrated, it is more of a theoretical. And unfortunately, this was not planned, so I don't have the video of it. What is intrathecal drug delivery system? As the name goes, it is delivery of the approved medication, because there are only few medications that's approved to be delivered intrathecally in the intrathecal space with a flexible catheter, and that's already programmed with a pump to ensure the measured amount of the drug into the space. Now we have to go for the indications and contraindications. It's more of a theory, as I say. It's inadequate pain relief from the current conventional medications. Patient is already tried on, and then when it's all failed, then you go for this option. And inability to increase the dose due to significant systemic side effects. As we know that all the drugs have the side effects, and patient won't be tolerating the higher doses, and they go for the either they have the, you can say, they become addict to it, or there are side effects. So you have this option with you. Now it is mainly cancer pain and the non-cancer pain. This system is more for the cancer pain, and it has come up for as a rational option for the long-term treatment of the cancer pain. For the chronic non-cancer pain, there are evidences, and still it hasn't proved that you can use this, but in certain failed back surgery syndromes, it is definitely working. That's what we have experienced. Now, what are the indications? The first and foremost one is the neuropathic pain. There can be, that's because of nerve injury, the phantom limb pain, the sympathetically mediated pain, then herpes, then arachnoiditis, central thalamic pain syndrome, or polyneuropathy. Then it is very much indicated for the relief of spasticity and spasm. What are the approved medications to be delivered intrathecally? That's baclofen for the spasticity, and zyconodine for the severe pain. Other medications, what we can use is hydromorphone. I mean, this is all depends as that availability of the drug in the different countries. The hydromorphone, bupivacaine, methadone, fentanyl, midazolam, clonidine, and neostigmine. At our place, we are using bupivacaine, fentanyl, midazolam, and clonidine. Neostigmine I haven't used much. Then we all know the potency of the morphine. It is the first drug of a choice for the cancer patient, and for the intrathecal it is 1 milligram. We all know the different physiology of the opioids. I won't go into detail, but mainly we should concentrate on morphine and fentanyl. Methadone, I don't know it is available here or not. Now there are two kind of things. It is either lipophilic or hydrophilic. Now we should know that when it is hydrophilic, it has a slower access, so that the onset is going to be delayed. The slower to clear, so it's going to be longer duration. The poor penetration in the fat, then better rostral spread, and the side effects includes the respiratory depression and nausea. The lipophilic drug, it's more rapid access to CSF, so it's quicker onset, slower in duration, then greater penetration in the fat, and greater in the vascular uptake. Then there is going to be significant blood levels, and there is lesser side effects in the central nervous system. Now, we should know about the latency of these analgesics we are using. If we concentrate for the morphine, it's up to 60 to 120 minutes for analgesia, and the duration is about 18 hours. And fentanyl, it's 50 to 100 mics, will give you about 15 to 30 minutes, and the duration will be about 4 hours. So in our setup, we use mainly the fentanyl that's commonly used by everyone, and morphine. And how we are going to put the intrathecal pump? You have to introduce the catheter. So where you have the pain, you first locate it, and then the tip has to be around that area. So this is here, and when the pump is introduced, it's just like we perform the spinal anesthesia, but it is done with the epidural needle, through which you put the epidural catheter, and then the pocket is formed either at the back or in the front. And I mean, simply we can do it, it's just a small incision. And why we select areas at the back in the upper, you can say where we inject normally. So the upper outer quadrant and here in the upper anterior abdominal wall. So when you carry out the routine activity, it doesn't hamper your routine activity and doesn't give a pain. Now it can be as a single bolus as we do it in the epidural, and it can be as an intrathecal and continuous infusion again in the same way. The trial success you have to do, and it has to improve 50% of pain and improve the quality of life, and it should decrease the dose of oral medication you have given to the patient, and then you think of the permanent placement. The permanent placement is done either with the general anesthesia if your patient is very much anxious and not cooperative, or if your patient is cooperative, then you can go for the monitored anesthesia care. You have to make the patient lie down in a prone position or lateral, and it has to be performed under fluoroscopic guidance. And you have intrathecal catheter. The site of insertion is normally the lumbar area. And we discussed about the lipophilic drug, because if the location of the tip is very important. If the drug is lipophilic, then it has to be closer to the site of action, and if it is hydrophilic, then it can be anywhere. The common complication includes the infection, as we know, the bleeding, the nerve injury, and spread of the tumor. The catheter related are the dislodgement, as we know, if it is not properly fixed. Then there can be kinking, dural puncture, headache can be there. There can be migration of the catheter anywhere if it's not fixed up properly. And there can be catheter-related granuloma, and that can lead to neurological deficit. So you have to keep on following up your patients. Then pump-related can be malfunction, there can be overdose. You have to keep on checking up the programs, whether it is functioning normally or not. Then there can be delayed respiratory depression, and if not taken care, then patient can die. The medicine related, as you know, there can be weakness, pruritus, as all opioids have. Then nausea, respiratory depression, apnea, and hypertension if there is a drug overdose. Then pump refills are required. They have a life, the battery life and the pump life. And if the drug is not delivered properly, you might have to readjust the dose calculation, and you have to refill. Then the side effects treatment includes, I'll go for it. We know that if it is you have to instruct them. If the respiratory rate is around 8 to 10 per minute, then you have to inform. Then 3 to 12 hours after the bolus of the morphine is given, it is very much important to observe them. Then it is less common with the fentanyl, we know that. And the naloxone should be there, and you should be ready for the infusion if it worsens. Then sedation after the surgery, you have to see for the systemic opioid effects, the decreased rate of infusion to treat that. And again, you have to go for the naloxone if it is there. Then pruritus, it can be mild or moderate. It is never severe. It is symptomatic and it is not related to histamine. And you have to check out whether it is enhanced crosstalk between the interneurons. Then treatment, we know that naloxone, butorphanol, and nalprofen, and Benadryl. Benadryl is the commonly one used. Then there can be granuloma. Because of that, the early diagnosis has to be there. Otherwise, there will be permanent neurological deficit, and you have to check whether it is diffuse sensory and motor changes. Then poor pain control, and MRI is the diagnostic tool to diagnose that. You can see it over here. And local anesthetic, mainly we are using the bupivacaine. Ropivacaine, still it's not commonly used for the spinal, and it has got more of the sensory. Later on, they might use it. Lidocaine, again, it is short-acting, not used much. And tetracaine is neurotoxic, so we do not go for it. Bupivacaine is the common one. We know the side effects. Clonidine, again, it can be used as an adjuvant, and it's going to prolong the effect of the local anesthetic, and it has got a synergism with the opioids. And one has to keep on looking for the pulse rate and the other systemic effect of it. And it is very much effective for the neuropathic pain. The side effect is sedation, and as I said, cardiac effect has to be monitored when you use clonidine. This is not available, but this is very much uh, for the neuropathic pain, and it blocks the N type of calcium channel blocker, and it has got a very narrow therapeutic index. To be very frank, I have not used this. Side effects are in mainly the CNS. Neostigmine, we are commonly using this for the reversal, but this can be used intrathecally. And we know that it is going to increase the availability of the acetylcholine at the dorsal horn cell, and it's going to increase the opioid effect. And there is a significant side effects with a narrow therapeutic range. Baclofen, it's available and it can be used in a single dose, or it can be used in a pump. Again, you have to keep on checking out when you use the baclofen. You have to be in touch with the patient. With all these things, when it is for the spasticity, you use it. The physiotherapy has to be continued, and you have to see that the pain increases or decreases, and accordingly, you try to set the dose. And to conclude the talk, it has been used successfully for the cancer pain, chronic pain, and severe muscle spasticity. Thank you.
WIP and editor of the Indian Journal, to present his topic, Interventional Pain Management. What is the evidence?
Actually, today we have examined the patient yesterday, and today we will be performing 5 procedures, 4 or 5 procedures. So we was not aware exactly what will be the cases, live cases. So it was selected only yesterday. Ideally, we thought that we will be discussing all these procedures before going to this, so that you can have a very clear idea about what we are doing. But unfortunately, all those lectures was not ready with us. So Professor Gauhar